Good morning. Welcome back to Open Med School case based discussion. Today I will be discussing the history of a patient. So, this is the patient, a 16-year-old girl who had history of myoclonic seizures which was progressively getting worsened, was started on sodium valproate. As you all know, sodium valproate is the drug of choice for myoclonic seizures. After a few weeks, she was brought to the emergency room because of altered sensorium. She had history of fatigue and anorexia for the last few days, denied fever, chills, nausea, vomiting, headache, abdominal pain, diarrhea or constipation. The relevant investigations were the AST level, that is SGOT was 1200, it was very much elevated. The ALT or SGPT was also elevated, 700 units. The serum ammonia was 184, that was also elevated. Her total serum bilirubin was 3.5 milligram per deciliter. So, the question comes, what is the likely cause for this? As we know, sodium valproate is widely used for lot of conditions. It is a broad spectrum antiepileptic. It is effective for all forms of epilepsy. That is one point to be remembered. It can be used for generalized epilepsy, absence epilepsy, partial epilepsy, myoclonic epilepsy, photosensitive, any type of epilepsy. So, it is a broad spectrum, antiepileptic. Second, this can be used for psychiatric disease like bipolar disorders. It is used in the prophylaxis of migraine, and the mechanism of action is varied. First and foremost, it blocks the sodium channels. It increases the level of GABA in the nervous system, presynaptic and postsynaptic region, because it inhibits the GABA transaminase enzyme which destroys the GABA. It also depresses or suppresses the action of glutamate, and it blocks the T-type calcium channels, and that is why it is effective for management of absence seizure. So, it is a widely used drug, and so we should be beware of the side effects that can occur. So, valproate can lead on to hyperammonemia and encephalopathy. So, here a patient has got increased ammonia level. A good number of patients on sodium valproate can have a raised ammonia level, but this hyperammonemia is usually not associated with any rise in transaminase. So, in our patient, she had rise in transaminase, very high transaminase, plus there is a elevated serum bilirubin. So, this is not a hyperammonemia produced by sodium valproate. Sometimes hyperammonemia can lead on to encephalopathy, but the differentiating point to be looked into is whether the transaminase is elevated or not. Second possibility is a drug induced liver toxicity. This is called DILI, drug induced liver toxicity or hepatotoxicity induced by sodium valproate. They are divided into two types. One is the type 1 and second is type 2. Type 1 DILI type 1 is a mild one, it is mild. So, it usually will not produce much liver toxicity, it is a mild rise in transaminase. And so, here our patient has got a significant rise in transaminase level, plus there is additional rise in serum bilirubin and has altered sensorium, indicating patient had a hepatic encephalopathy. So, this comes under DILI 2. So, DILI type 2. So, that is the, so here it is, this diagnosis hepatotoxicity due to sodium valproate. Usually it is an idiosyncratic reaction. Overdose can also lead on to, so idiosyncratic reaction to sodium valproate leading on to DILI 2 or valproate induced hepatotoxicity. As already mentioned, valproate induced hyperammonemic encephalopathy, it is due to inhibition of the carbamyl phosphate synthetase. That is one of the crucial steps or the major step in the urea synthesis. But as mentioned here, then the normal or near normal LFTs. So, that is a point to be kept in mind. We have discussed the delete type 1 and delete type 2. So, what is the pathology of valparin induced hepatotoxicity? So, it produces microvesicular hepatosteatosis, that is there is a steatosis or fatty liver is occurring, it is microvesicular, and this microvesicular, this is due to mitochondrial toxicity, and in that is mitochondrial oxidation, that is beta oxidation is blocked. So, that is a pathology of valparin induced hepatotoxicity. You can see here the picture, you can see the microvesicular hepatosteatosis. The significance is DLE has got a very high mortality ranging from 11.7 to 17.3. The serum carnitine level may also be looked for, and screening for urea cycle disorders can be considered in valparin induced hepatotoxicity or hepatic encephalopathy. So, these are certain enzyme defects that can lead on to or increase chance of development of valparin induced hepatotoxicity. One among them is the mitochondrial disorder, that is the myoclonic epilepsy with ragged red fibers. So, here the muscle biopsy shows the ragged red fibers. So, this is a mitochondrial disorder. Here the differentiating point is they will have increased lactic acid. Lactic acid is increased in serum and CSF, both can be increased. So, in a hepatotoxicity produced by valparin, if the lactate is very much elevated, think about the possibility of an underlying mitochondrial disorder. Genetic tests are available. You can look for the mutations in the nucleotides A to G that is occurring, which will be present in 80% of MRF patients. So, one word regarding the MRF. Myoclonic epilepsy, sodium valproate is the usual drug of choice, but in mitochondrial disorders, as it decreases the carnitine uptake, it may precipitate liver failure. And so, some authors recommend levetiracetam, topiramate, clonazepam for the treatment of myoclonic epilepsy in a patient with MRF. And again remember, carbamazepine, oscarbazepine, phenytoin worsen the myoclonic epilepsy. So, the drug of choice for myoclonic epilepsy is sodium valproate. This is again another important point to be kept in mind. In short, we have discussed about the mechanism of action of sodium valproate, the two major side effects of sodium valproate, that is the valparin induced hyperammonemia and valparin induced hepatotoxicity, and we have given a bird's eye view of the mitochondrial disorder, especially the MRF, which can also increase the chance of hepatotoxicity. Hope this session was useful to you. We will come with another topic next week. Thank you.